Okay, good morning, everyone. Is it my voice clear for everyone?
Yes, it is.
Okay.
Can
One
we?
second. So, hello everyone, good morning and welcome to the 5th annual general meeting of Saudi Midwifery Group, day 2. Today, our program, it will divide for 2 sessions and 1 break. And I'm too much glad to see all of you participating to this event and empowering midwives in Saudi Arabia. My name is Huda Hammami. I will be the moderator for today. And I'm the General Secretary of Saudi Midwifery Group. So we need to start and to welcome Miss Irina from New Zealand. Miss Irene, she's a registered nurse midwife. She's a postgraduate certified in health professional education and international lecturer. She's a foreign expert maternity service and midwifery advisor to a modern maternity service system. She's also director of Operation My Body, My Baby, Enhanced Perinatal Global Education Project. She's also Homeopathy Midwifery Advisor. Welcome, Miss Irene, and thank you to be part from our day.
So, hi everybody. I could probably say Salam Alaikum. I'm very privileged to speak to all of you today. My name's Irene Chain Kalinowski. I've been a midwife for 40 years and I've worked through many continents, from England to Saudi, where I worked in Riyadh and Jeddah, Bahrain, Oman. I went back to the UK, back to Saudi Arabia, and then I landed myself in New Zealand for 20 years as an LMC midwife. And then I went to China for 5 years. So today I'm just going to share with you a little bit of my experience, because I saw so many gaps in my travels with midwifery education, and also the gaps between obstetrician and midwife care. So I spent a lot of my time in China bridging those gaps. So first of all, one of the biggest issues I see is that even in our curriculums and our competencies for midwives, it doesn't have an integrated module philosophy. So I find that even though we support the normal physiology of childbirth, our approaches are often very medicalized, and it misses the holistic, integrated skills to prevent the complications in pregnancy. And when I worked in New Zealand as an LMC midwife, in the beginning, my C-section rates were very much higher. But when I studied homeopathy and other complementary therapies and put them into my practice and treat the woman as an individual, my vaginal birth rate reached 95%. And all the women celebrated birth with me. So I kept saying, why don't we change this? This needs to change. Our approaches need to change. So who informs midwifery educational standards? Well, we can't inform practice with what we don't know. We can't inform it if we don't have an integrated holistic mindset that sees the woman, her body, that everything's connected with the mind body, yes. And most of our training, as I said, has been a very medical model despite supporting normal physiology. Most midwives think medical, and we all need a holistic mindset that's not found in any of the medical models. And if we look at the traditional art of midwifery, we know birth process can be made easier when midwives are taught the art of midwifery. Midwives are taught the mechanics of midwifery today, but we can say that they're not truly taught the art of it. And obstetricians are not trained in it either. So we need to teach instinct, grounded decision-making, teach health professionals how to meditate, how to center themselves before making decisions, how to actually look into themselves. And, you know, a lot of grounded decision-making is lost through prescribed midwifery training, through rote protocols, instead of looking at individual situations and working out the bigger picture and then acting upon it. And observation is the key element of homeopathy and Chinese medicine, and it goes hand in hand because it is the art of midwifery. American midwives have homeopathic training in their curriculum, and in Sweden, homeopathy is actually funded, for example, by the government health system. So our training and education needs to change, and I'm going to talk about how we changed it in China very shortly. So let's look at what happened many, many years ago. In 1878, a lot of the doctors were obstetricians were homeopaths. And if we look at the statistical data of the mortality rates, the homeopathic, which is the holistic kind of approach that takes the whole woman into consideration, mind, body, the individual, the mortality rates were 0.1% in 1878. And Western medicine in the UK was 1%, higher in New York, 1.2%, and in Philadelphia, it was 3.4%. And at the same time, the complications of uterine infections, convulsions, and postpartum hemorrhage from 45,000 documented births show that homeopathy in itself had the least complications, 1.5% of when it's used in the UK, 2% in New York, and in Philadelphia at 0.5%. And look at the difference between our Western medicine approach. It's as high as 20% in 1878. So despite advances in modern technology and drugs, modern medicine has never reached the 0.5% with a pure and simple homeopathy over 100 years ago. And for example, homeopathy is not just giving a medicine to a woman, it's fixing the entire thing. So it's fixing the external influences that can affect the pregnancy. So it reduces the stress, it looks at the environment of the woman, it looks at her diet, her lifestyle, and we treat her emotions, because when a woman's stressed, she can develop things like diabetes even if she's eating a healthy diet. So we are changing, because now we've got obstetrics and gynecology applied to Chinese medicine, recently released 2011. Yeah, and traditional Chinese medicine was applied to clinical practice thousands of years ago. And the use of TCM, we know, helps to improve the negative emotions of patients and improve the overall satisfaction rate of women. So why don't we have these things, and why don't midwives and obstetricians learn the basic philosophies so they can apply it to their practice? So in China, we went to Tiandong, we went to the southern part of China near the Vietnamese border. And the difference there is that the midwives and obstetricians already had a partial holistic mindset. They were using some traditional Chinese medicine, but they still had a medical approach to childbirth. And when we went to these hospitals, the obstetricians, the midwives, they were crying, they were fearful of birth, and they were more fearful of litigation, they were overworked, and they were tired. So I was very privileged because I did audits. And I went into the clinics and I audited the obstetricians, the midwives, and the nurses to see what care and advice they were giving to women. And it was very poor in the beginning because it was more system-centered, where the woman would actually go and see an obstetrician who would order the blood test. She'd go off, she'd go to another place, get the blood test, she'd come back. So I even calculated that the length of time with an obstetrician was only about 1 minute and 30 seconds. But if you counted the whole time together, it was actually 20 minutes. And this is how long the midwife clinics should be. The women appeared to be distressed because the obstetricians and midwives couldn't answer the simple, basic issues that come with, treating a bit of carpal tunnel or treating the minor backaches. They didn't have the answers. So women would get frustrated too. So when we changed the whole training and we taught all midwives and obstetricians a holistic way, we taught them diet applied to obstetrics and applied with the physiology, and how to prevent the complications, how to prepare the woman for birth. And if you can see by these pictures, you can't tell who's the midwife and who's the obstetrician because they're all using tools, the doll and pelvis, the flip charts, to explain things to women and to work as an interprofessional team. So we had the obstetricians and midwives in the same classroom. The midwives and obstetricians learnt normal birth. They learnt the physiology of it and how to manage it. And the midwives also learnt with the obstetricians work together so they understood the complications of pregnancy. Because if you don't know the complications, you can't prevent them. So after our training of 2 months non-stop, we had happiness in the workplace. We created a shared philosophy between obstetricians and midwives. They trusted each other. We opened midwife clinics next to the obstetrician's room, and they were best friends. They would just go in and out and support each other. We created openness and transparency. So yes, the same philosophy is very, very important. And once they shared that philosophy, we had no conflict. There was no ego. Everyone were equal members of the team. The fear of litigation was removed because they felt confident and the woman was in control. So the woman made the decisions. And the fear of childbirth was removed. So happy women and families. So there were happier women and the families were better with their outcomes. And the staff were skilled in the traditional therapies to take care of themselves too. Offer women many safe avenues that fix problems and sustain emotional, physical, and spiritual wellness. So the art becomes returned through observation and connectedness. So first and foremost, we're all prenatal educators, obstetricians and midwives, and we taught them and trained them how to provide holistic prenatal education that applies the physiology so the women understand their own bodies. So the obstetricians and midwives can answer and resolve the woman's problems at every point of contact, even in the prenatal classes. It takes turns in teaching the classes, and they join together and make the classes together in a language that all women can understand. So the entire system sends out the same message, so it doesn't matter which obstetrician or which midwife the woman goes to, she's not getting confusing, conflicting advice. And with the use of interactive educational tools provided in every department. So what does it mean for the woman and a family? We saw reduced post-traumatic stress disorder. The woman stays in control. Better partner and family relationships because we teach the partners and support people the basic meditation skills, massage skills, and how to connect with each other and identify their roles in the birthing environment. So when women are supported by a family who's coached into understanding the labour and birth process and taking care of her, we get more satisfaction in the care. And happy that most of the woman leaves the clinic feeling happy. Every woman should walk out of a prenatal clinic feeling confident and happy, and that most of her issues are resolved. And that she's cared for in a safe and loving environment. And they need trust and they build trust in the system. As you're able to resolve the small issues, the woman develops more trust in you. So can we get to the root cause of things? When we talk about diet interrelationship of the pathophysiology of preterm birth, preeclampsia and diabetes, and in relation to hemorrhage, and we know the key point, the latest research is telling us nitrates, nitric acid, acid that becomes nitric oxide. Well, too much nitric oxide, yes, too higher levels, you'll hemorrhage, and too little, you'll get diabetes, preeclampsia, because it's involved in constricting the blood vessels. Now, obstetrical research is looking at giving medications to increase nitric oxide levels. But is that enough? Because we know stress reduces nitric oxide levels. So we can give a pill, but if we don't have the skills to help the woman reduce stress, emotions, look at her environment and fix the lifestyle, the little pill's not going to do very much. And if you look at diet, such as beetroot, and especially in China, the Chinese fungi is full of nitrates, which will actually increase the reduced nitric oxide levels. And this is the education we midwives and obstetricians need to be able to support women and prevent those problems happening. So we can prevent this. If we take care of women early, we can prevent the IUGR babies in many, many cases by this integrated approach to care. And that's why the curriculums need to involve this in the care. We get many specialists will come and talk about hypertension, high blood pressure, but they often how to treat it, but they fail to say how we can prevent it. What do we see when we see stretch marks? I know midwives usually say to me, oh, hang on a minute, we just put some cream on them. Well, when you see this, what implications does it have for labour, birth and the postpartum period? She's got poor collagen. Her skin is not stretching, is not stretchable enough. There's no elasticity in it. So she's missing the zinc, the magnesium, the protein. Yeah. And if you don't have those nutrients and you see these stretch marks, it could mean that she's more prone to 3rd and 4th degree tears because of poor perineal tissue or poor wound healing. So if we can fix the diet early in pregnancy, and what I found in my women is that I rarely saw women in my care with stretch marks. And if we did get 1 or 2, we would automatically talk about the diet. When I talk about rote prescribing, let's look at shoulder dystocia. You know, a lot of us will run in and do a Mac Roberts maneuver, and they will lift the woman's legs up towards the chest, which is a good position. But if you open the legs out, it's not a good position, and it closes the pelvic outlet. So how can you rotate a baby easily with your hands if you're already closing the outlet? So we need to apply physiology into what we're actually doing. So most of you might know the sit bone test. So if you sit with your hands on your sit bones, like the picture there, and you can try it. If you put your knees out, you'll feel the pelvic outlet close. But if you put your knees together with your ankles out, you'll feel the pelvic outlet open. So what's the future vision? When I was in China, we actually have developed 5 midwifery textbooks, and each book has probably 700 to 800 pages, which is twice as much as one common midwifery textbook that you might see today. And we split it up into applying the physiology, adding the safe complementary therapies that midwives can utilize to prevent the problems. And it includes the understanding the mind and body. So we have prenatal care as a module, and from those textbooks will come educational modules for the midwife under each section, and then there'll be forums every month so that the midwives get an opportunity, or the student midwives, to discuss the practical realities. So in other words, it will bring the knowledge from the books to life and take everything into clinical practice. So online education's very important in this modern age, and it can be very, very beneficial. We do the same for labour and birth, newborn care, and we don't split newborn care from infant feeding because it's a dyad. And in newborn care, the midwife not only learns the examination of the newborn, but applied physiology to prevent problems. And when nursing the newborn baby, we learn all about the innate reflexes and how to support them. And postpartum care is the same kind of setup with the integrated perspective behind it. So it has a complete medical model, which is integrated with a lot of preventative and supportive therapies that will give us better outcomes. And the first section is the foundation, which is actually an online learning module for the midwives to do. So we come to the future vision of having online learning modules, like I've just explained. It needs to integrate the medical model with the holistic mindset of complementary and alternative options. So the midwives are trained in the basics of aromatherapy, massage, homeopathy, acupressure, and meditation. So each foundation textbook has an online learning modules for each section in the books. This is what we're doing in China, and it's just evolving. We are anticipating online forums to be held monthly for each domain to support and discuss clinical practice. And a clinical midwife educator on ground level in every hospital there, because there are no home births in China. So then they get ground level face-to-face training, and it all beautifully complements one another. So I'm going to say thank you. I hope you found it informative. I really want to answer your questions, and I'm contactable at chainirene@gmail.com. That's a small c in front, all small case, chainirene@gmail.com. So thank you all. I hope you enjoyed listening, and I look forward to hearing your comments. So bye.
Thank you very much, Ms. Irene, for this beautiful lecture. Actually, I enjoy it. I enjoy the most part that you talk about how it's a start. Everything starts from inside. We need to take care from our diet to release the other problems. We will not cure the last thing. For example, I like also the stretching mark example. It's all about diets. We need to make more attention for the diet during pregnancy and how the mother should prepare herself. It's very nice. My question is, what's the most traditional step or thing that you take from the Chinese medicine and you apply it for the pregnant ladies, and you feel that it's really effective and it helps?
We use a lot of acupressure points, and use a lot of combination herbal teas to support the woman postpartum. Chinese medicine, actually, you know, when the woman comes to a clinic, they will take the woman's pulse and they'll just feel how vigorous the pulse is. And by doing that, they can actually assess the woman's emotional state. as well as the physical stage. It's very interesting because we do that in homeopathy too. We actually can sense how healthy a woman is by feeling the pulse. You know,
do you find it's really helping? And do you feel like it's really helped the mother to reach that level of emotion stabilization during labor?
well, I think homeopathy plays a more important role and works very quickly, more quickly than Chinese medicine for that.
Okay, great.
We trialed, okay, we trialed the combination remedies. I put 34 together because I went to New York 2 years ago to set up a homeopathic course for midwives, which is midwifery input. And with that, I developed 34 combination remedies because it's easier for the midwives to use with the basic skills and knowledge of homeopathy. And we trialed it in China, and they were just so amazed as to how quickly they can calm an anxious woman down and support the process.
Okay, great. Thank you. The second question is it easy to implement this new vision and the new guidelines and the new philosophy of birth in China, especially that, as you mentioned in your lecture, that it was just not common and it's new for them.
Yes,
So, what's your biggest challenge for you to start this or to establish this opinion or this new philosophy of birth?
well, you've got to go back to the history of the influx of Western medicine into China. The stronghold is in the main cities. It's very obstetric run. There's very few midwives there. So we went to the remote areas and we're spreading outwards in. So we've gone to the places where it's more accepted, and then they're seeing the results. They're seeing the reduced C-section rates, the reduced interventions, and we know it's going to sweep inwards. So you can't go to the heart of it because it's very difficult to change the medical mindset and the openness to the integrated model.
Yeah, thank you. And it's a great effort to start this in China, and hope we can take a few and we will reach that level also in Saudi Arabia because we really start in a good way. Thank you, Miss Irene, for your time and for a nice presentation. And now we can go to the next presentation with Dr. Nawal Abdel Ghani. So welcome Dr. Nawal Abdel Ghani. She's a honorary research at Judy Lumine Center University. She's also a lecturer in Al Qura University, Mecca. She's from Saudi Arabia, and her lecture today is How on the Baby, a mixed method study of skin-to-skin contact after a vaginal birth in Saudi Arabia. So welcome Dr. Nawal, and we will start the lecture.
Assalamu alaikum wa rahmatullahi wa barakatuh. Peace be upon all of you. Good morning, everyone, and welcome to my presentation. I would like to thank the Saudi Midwifery Group for inviting me to present my work, and for the amazing organizers and the scientific committee for all their amazing job. I'm very honored and excited to present what I've been working during my last 4 years of my PhD, which I just recently completed. So today my topic is Who Owns the Baby? A mixed method study of skin-to-skin contact after vaginal birth in Saudi Arabia. I would like to acknowledge the support and the encouragement during the tough time of COVID-19. I would like to acknowledge and thank my supervisors, Associate Professor Lisa Amir, Dr. Christina Adverson, Dr. Amanda Coughlin, and for the study participants, and also big thanks to my sponsorship, Al Qura University, and for the amazing place for where I did my PhD, Judith Lumine Center in La Trobe University in Melbourne, Australia. For those of you who are not familiar with Saudi Arabia, this is the map of Saudi Arabia, and here is my hometown, Jeddah. Jeddah actually is the second largest city in Saudi Arabia with a population of 4 million people. It is a multicultural city. It has very special landmarks, which I'm going to show you in the next slide. So as you can see, the right photo or the right picture is for King Fahd Fountain, the largest fountain in the world, and the left picture is Al Corniche Beach during the sunset, and the other one during the sunrise. And wait for more pictures to come during my presentation. Okay, so back to my topic. Why is skin-to-skin contact is important? Why is skin-to-skin contact important? Why do we care about it? So skin-to-skin contact is the placement of naked baby on the mother's bare chest or abdomen. The evidence from the Cochrane reviews by Elizabeth Murray et al. In 2016 support the practice of skin-to-skin contact soon after birth due to the physiological, psychological, and social benefits for both the mother and the baby. So when we place a baby, the naked newborn infant on the mother chest, on the mother bare chest or abdomen, we give the infants the chance to progress through the 9 instinctive behaviors that start with the birth cry, and then the baby progresses to be familiar with the mother smell, and then the baby starts to crawl and then will reach the nipple and suck it and self-attach it, which we actually want the baby to do. So skin-to-skin contact is the key success. It's the key success for successful breastfeeding, as many studies proved. So, since the Baby Friendly Hospital Initiative was launched by the UNICEF and the WHO in the 1992, the practice of skin-to-skin contact was less focused, and then through the other document, until the last revised document clearly in 2018, where clearly defined the practice of skin-to-skin contact and recommended to be immediate, continuous, and uninterrupted for the mother-infant diet, and that clinician should facilitate it and encourage it as soon as possible after birth for at least the first hour. And also they recommend a global standard of at least 80% of all mothers to have skin-to-skin contact regardless of type of birth, unless medically justifiable to delay the contact. So despite all this recommendation, the separation between mother and infant still happening. And actually, we don't know how common is that. How common is the practice of skin-to-skin contact around the world? And in Saudi Arabia, there is a lack of researchers reported the practice of skin-to-skin contact. There are only two or three studies where they reported the practice from an administrative level, as unit managers or from healthcare providers, but not actually the mothers who reported the practice. And therefore, it's not reflecting the current practices of skin-to-skin contact in Saudi Arabia. So in order to address these gaps, the study aim, or the research aim, was to determine the prevalence of skin-to-skin contact worldwide and to explore the current practices of skin-to-skin contact immediately after vaginal birth for healthy term newborn infants in the 2 largest public hospitals in Jeddah, Saudi Arabia. The research project involved 4 studies, which I will explain in the following slides. So the first study was a review, and the aim of this review was to systematically describe the reported prevalence of skin-to-skin contact for healthy mothers and infants immediately after vaginal birth, from data published between 2007 and 2017 worldwide. The primary outcome for this review was the prevalence of skin-to-skin contact for healthy newborn infants more than 37 weeks of gestation after vaginal birth. The secondary outcome were the starting time of skin-to-skin contact and the duration of skin-to-skin contact. So the review was published in PLOS One in 2018. a total of 5,000, more than 5,000 records were reviewed. Of those, only 35 studies or 35 studies met the inclusion criteria, and we included in this systematic review. These 35 studies represented 28 low, middle, and high income countries. So what we found in this systematic review, we found that first, there was a lack of agreed definition about skin-to-skin contact. There was a wide range in the practice of skin-to-skin contact for mothers infant diet around the world. As you can see, from 1% in Tanzania to almost 98% in Croatia. And this data published from 2007 to 2017. Most of these studies were from, as you can see, from high-income countries, and these reported higher rate of skin-to-skin contact than studies from low and middle income countries. Also, we found that few studies were conducted with a primary aim to measure the practice of skin-to-skin contact worldwide. The settings of this research project, which is going to be in study 2, 3, and 4. So the study settings was conducted in 2 hospitals, Hospital A and B in Jeddah, Saudi Arabia. Both hospitals are public hospitals with approximate annual birth of 7 and 6,000 respectively. Ethics approval were obtained from Latrobe University, Human Research Ethics Committee, and the Saudi Arabian Ethics Committee of Directorate of Health Affairs in Jeddah. At the time of the data collection, around 112 obstetricians rotated through labor, delivery, gynecology, antenatal, and postnatal ward at the 2 hospitals. And approximately 82 midwives and nurses were working in the birth unit at the 2 hospitals at the time of the data collection. The birth units consisted of single rooms for birth and labor with an average of 6 rooms in both hospitals. The data were collected between June and September in 2017. Okay, so study 2, it was an observational study of skin-to-skin contact in Jeddah, Saudi Arabia. So the aim of this study was, the primary aim was to investigate the current practices and policies about skin-to-skin contact by observing mother-infant diet in the first hour after vaginal birth. The secondary outcome was to observe the infant's 9 instinctive behavior stages and breastfeeding initiation in the first hour. So we used non-participant observation, field notes, and review field notes. So we use non-participant observation, combining quantitative recording of observation with field notes and document reviews of guidelines. Study 2, so in study 2, the participant and the recruitment, most women who gave birth at these 2 hospitals were not booked in. So, which I mean that they had no medical file or antenatal records at admission. Therefore, so we invited the women to participate in the study when they were admitted for birth, but they were still in early stage of active labor. Women were given the participant information statement and were informed that their participation was voluntary. Also, women were given time to consider their participation, and they discussed that with their partners or with their families. So when women interested to participate in the study, I approached the clinicians who managed the birth to get their permission as well to be able to observe the birth. So, and clinician included obstetricians, midwives, and nurses. So you can see this flyer. So this flyer was placed on the memo board in both birth units in the 2 hospitals to inform the clinician and the women about the study. For the data collection tool, so we've used the birthing room observational tool that designed by Roth Cantrell et al. In 2014. And this tool actually measured or described the first hour post-birth, minute by minute, was selected to, so we selected this tool because it recorded the observation and because it was the most comprehensive tool identified and therefore was the best suited for the study context. So this tool divided into 4 sections. The first section describes the practice of skin-to-skin contact and any event occurring during the first hour, occurring immediately after birth. And the second section identifies the 9 instinctive newborn behaviors that the infant progressed through in the first hour, according to Anne-Marie Wedenstra. The third section of this tool explains the maternal experience of initiating breastfeeding, and the fourth section describes the assistance that the mother received to breastfeed her newborn infant. And for the data collection, so the observation were unobtrusive with minimal interaction. So I had no interaction with the participant or with the mothers or with the clinician. And I confirmed with the mother again for the second time and consent her again in the birth room. So when the birth started, I entered the room and started recording events occurring during the 60 minutes after birth. In some cases, I had to stay longer if skin-to-skin contact or breastfeeding was occurring. For the data analysis, so data were entered in EBIDATA and transferred to Stata 15 for descriptive analysis. Results were displayed graphically for each infant, which I'm going to show you in the next slide. The field notes were analyzed by using the content analysis approach. So the results of study 2, both hospitals mentioned skin-to-skin contact practices in their immediate postpartum policies. However, Hospital B had more explanation and details about the practice of skin-to-skin contact. I will present just the primary aim for study 2. So as you can see in this flow chart, which provides a detailed description of each infant's care received during the first hour. So the red arrows filled with the white color is the time where the newborn infant were separated from the mother, and the reason I'm not expecting you to read this abbreviation, but this abbreviation actually here on the right, where this is actually the event interrupted skin-to-skin contact. So as you can see, it's very clear that all babies were subjected to separation from their mothers, and many events interrupted the practice of skin-to-skin contact. The blue arrows shows the blue arrows show that out of the 22 newborn infants observed, 16 infant had placed on the mother covered chest or abdomen. And this is actually what we found was very interesting, that some of the clinicians, they put the baby on the mother chest or abdomen, but with a cover, with a barrier, whether it was the mother gown or sometimes they got a waterproof sheet and they put it just only because they want to put the baby on top of it. So 16 out of 22 had this practice where they placed a cover or something on the mother chest. And the green arrow, which I was desperately want to get, as you can see, out of the 22, only 2 mother-infant dyad had experienced immediate skin-to-skin contact for a duration of 10 minutes. It wasn't like in the last case on the 22nd, they had it immediate, but then they had a long time of interruption. Among those 22, 9 mothers initiated breastfeeding within the first hour after birth, which indicated in the orange arrows. during the observation, it's important to note that only 3 women received education about skin-to-skin contact from breastfeeding educators. For more information about the result of the observational study, here is our publication in Habitat. So what's special in Jeddah, just to kind of, give you a bit of break. So what's special in Jeddah, that we have a very amazing roundabout, and this is my favorite. It's called Linton Roundabout. Okay, so go to study 3. So study 3 is the healthcare providers' perception or perceived barriers and facilitators to implement the practice of skin-to-skin contact. So the aim of the study was to identify these barriers and enablers and what requirement they need to implement the practice of skin-to-skin contact. So we designed this study to be a qualitative face-to-face semi-structured interview. And for the participants, so we had 20 healthcare providers participated in the study, a purposeful sample of obstetricians, midwives, nurse midwives, and nurses who worked in the birth unit for at least 12 months experience. All participants were female because almost 90% of clinicians at birth units are female. All participants gave consent prior to the interview. The interviews were conducted in a time and place that suited the interviewee. The interviews were conducted in English and Arabic according to the interviewee preference. Some of them started the interview in English and then changed to Arabic. All interviews were digitally recorded except one where the participant did not consent to interview, did not consent the interview to be recorded. So I took note instead, and then the notes checked by the participant following the interview to ensure the trustworthiness of the data. And for the data analysis, so we used the thematic analysis, Braun and Clark, 2006, and that guided by 2 theoretical frameworks, Grohl and Winks, and Susan Mitchie, the theoretical domain for behavioral change. For the results of study 3, healthcare providers actually they buy in the value. They believe in the benefits of skin-to-skin contact. So they describe the importance of it. They describe it as magic hour sometimes. They perceive the practice to be simple, easy, and so they believe on it. They believe the value of this practice. And some of their barriers, or some of the existing or potential barriers to practice skin-to-skin contact was lack of capabilities and motivation to implement the practice of skin-to-skin contact. They said mothers, sometimes they're not interested to have skin-to-skin contact, lack of professional collaboration, staffing and time constraints, medical birth environment that prioritized interventions over skin-to-skin contact. Here are some quotes from the participants. For example, one of the midwives, she said, "I practice mother-infant skin-to-skin contact, and I know it's evidence-based practice. But I practice when I'm alone with the mother because I'm afraid that I will get negative comments like finish your work or finish your job quickly, or it's your responsibility if the baby falls down. I feel reluctant to do the practice. The problem if she means here the obstetricians said that in front of the mother will not trust me or my work." Another quote from a nurse midwife, she expressed her perception by saying all of them, obstetricians, midwives, and nurses, have the knowledge to provide skin-to-skin contact. But these changes are very hard and the process takes time. So the staff have to change their attitude and practice in this first hour of postpartum period. An obstetrician, she was very tired and she said, "I'm not saying that we could not perform the practice of skin-to-skin contact. Easy and simple, but all the other competing tasks, we find it hard to do. The problem will reach a stage where we just work blindly like a machine. We would love to spend time with the mother and educate them, but being busy all the time makes us tired and counting the time to go home. So quite a bit sad to see all these comments, but this is the reality. For more information and for more to read more about the results of this study, we published an article on midwifery about the qualitative study. And here is another beautiful landmark. It's called the Seashell Roundabout, and this is one of my favorite as well. Okay, move to the last study. Study 4, it's so the aim of study 4 is to estimate the rate of skin-to-skin contact and describe mothers' perception and experiences of skin-to-skin contact after vaginal birth in the 2 largest public hospitals in Jeddah and Saudi Arabia. So, and we used a cross-sectional descriptive study design. So for the participants were mothers who had vaginal birth at the postnatal ward in the 2 hospitals. And we developed a new survey based on the literature, and it has with 36 items. And this survey divided into 6 sections: demographic characteristics, mothers' description of skin-to-skin contact with their babies after birth, breastfeeding outcomes and infant feedings, mothers' perception and attitudes about skin-to-skin contact, source of information and support offered or received by the mothers. And the last section was a free text responses or open-ended questions. The survey was piloted twice in Australia and in Saudi Arabia. There were two versions, one in English and the other one in Arabic, for mothers to complete. For the data analysis, categorical and numerical data were described using appropriate summary, including proportion, frequency, means, and standard deviation. And other questions were the Likert scales, or the free text responses. And English Arabic researchers checked the coding, the themes, and the categorization of the text, and all the authors checked the translated coded codes and formed categories and themes independently. The result of study 4, it's under review at the moment, so I'm not gonna expand on this results because we're waiting for it to be published. I will just give you a bit summary of the results. So a total of 254 mothers completed the survey with a response rate of 92%. The rate of direct skin-to-skin contact was 15%. The same practice we observed in the study 2 also common, with half of the mother had placed the baby placed on their chest and abdomen with sheet, whether it was a gown or sheet, which around, as I said, half of them. Mothers held a favorable perception and felt comfortable practicing skin-to-skin contact immediately after birth with 67%. 85% of mothers did not express concern about feeling exposed, nor that skin-to-skin contact was inconsistent with their norms of modesty or culture. Here is our letter to editor that we recently published in Acta Pediatrica to reinforce the policy of skin-to-skin contact in general and during the unprecedented situation of COVID-19. So we try to enforce the practice of skin-to-skin contact, especially during the pandemic of COVID-19. Okay, so is there potential to increase skin-to-skin contact in Jeddah, Saudi Arabia? Yes, absolutely yes. The insight gained from identification of facilitators and barriers for skin-to-skin contact in this study can assist the development of a tailored multi-level implementation at different levels, at the individual, the social, and the organizational level, to provide continuous, uninterrupted skin-to-skin contact immediately after birth. If we address this recommendation, which is through developing as I said, developing a tailored multi-level implementation strategy, through updating the hospital policies that prioritize skin-to-skin contact over routine care, by sharing the evidence and the knowledge about skin-to-skin contact with the clinician and the expecting parents, and by acknowledging, most importantly, by acknowledging the mother needs and feeling towards skin-to-skin contact. If we address this recommendation, we could successfully implement skin-to-skin contact after vaginal birth, and we would work to implement skin-to-skin contact even after cesarean section in the future. And most importantly, we as a clinician, we really have to understand that we don't own the baby. Mothers who had the baby for 9 months, they deserve to have their own baby as long as they wish after birth. Thank you so much for listening to my presentation, and here's my contact.
Thank you, Dr. Nawal, for this nice lecture and to sharing all the studies, and you do a great job to comparing all the studies for the skin-to-skin and how to implement and to improve this practice in Saudi Arabia. Thank you also for the photos. It's very nice touch that you all the time including and promoting Jeddah, and in Arabic always Jeddah ghair. It was really nice. So please, if anyone want to give a question for Dr. Nawal about his lecture.
Thank you so much, Huda, and for all the amazing job you're doing, guys, behind the camera, and for all the the organizers and the scientific committee. It's my pleasure to be with you today.
Okay, thank you. So my question is, what's the most important point that we can implement to cross this barrier to improve skin-to-skin practice?
That's a good question, Huda. I guess I would say the most important step that we need to do as a clinician is to share the practice, to normalize it. What I've heard from some of the clinicians during the interviews, that they knew about the practice. It's not something new that they didn't know before. But I guess the barrier that it's not normalized. It's not like being implemented as a routine practice. But I guess if I'm in the birth unit and I spread that practice, and we kind of, talk about it all the time, we try to encourage each other to do it and work collaboratively, obstetricians, midwife, to implement that practice. It's not going to be hard. It's just that we really need to, take the step and start it. It's not that hard, something hard that we can do it. It's very, very simple, very easy, as the participant said.
Totally agree, Dr. Nawal. The hardest comment that I heard, and it's really, really normal and common, it's why you want to put skin to skin and finish your work first. Like it's not in our work or in our practice to give this mother that moment and to let her enjoy her birth and benefit for her and for the baby, that skin to skin moment and that skin to skin benefit for all levels. So hope soon, inshallah, it will be common, and this is the normal practice that you can give the baby to the mother for the first 10 minutes, especially now with the COVID-19 kind of some guidelines, they are agree, others they are not, and it's a little bit harder nowadays, but hopefully it will be improved.
Yep.
Thank you. Thank you very much.
Okay. Can I continue?
Okay. You need to add anything, you feel free to add it.
Okay. Yeah. And that's why I said at the end that we have to understand that we don't own the baby. The babies actually are the moms, and they really need to spend as much time as they want. And one of the comment that I received during the qualitative study, the interviews, that some of the clinicians said that the mother, they don't want to have skin-to-skin contact. But actually, the evidence from our survey that almost 70% of the mothers, they really wanted to have skin-to-skin contact with their babies, which is great, and it kind of contradicts what what some of the clinicians believe.
Okay, sorry, there is a question now from one of the participants. Did you face resistance from women? And that's what you mentioned in your lecture previously.
Yes, well, I think the mothers, they really wanted to have skin-to-skin contact. And the amount of motivation, and you can imagine how some of them, they were very sad. And we found that from their free text responses, they said, we feel sad that they took our baby from us. We don't have enough time with them. We didn't spend time with them. So the mothers, they really wanted to have their babies with them for the first hour. But most importantly, they need us to talk to them. They need us to ask them to take their permission when we put the baby on their chest. Some of them, they said, I was so shocked when the baby placed on my chest without any permission, without saying anything. I got so scared from the blood. So I think our role is to educate mothers. Sorry, I don't like to use the word educate. We really need to share with the mother this information and just let them know this is their nature. They really want to have the baby on their chest.
Okay, thank you for answering the question. There is any more questions? Thank you, Dr. Nawal, for this great lecture and for your time. And we can now welcome Dr. Sheena Byron. She's practicing midwifery for of 40 years. She's having worked in NHS for most of the time. Sheena was one of the UK's first consultant midwives, and as head of midwifery, successfully helped to lead the development of 3 birth centers in East Lancashire. As well as being an international speaker, Sheena provides consultancy service to both NHS trusts and organizations globally. Welcome, Dr. Sheena Byron, and thank you to be part of our day.
Hello, my name's Sheena Byron. I'm a midwife in the United Kingdom and I'm delighted to be with you today in Saudi Arabia. Thank you so much, Dr. Roa, for inviting me to this prestigious event. So I'm going to share my screen with you now and hopefully my slides will be there. My talk's going to focus on normal birth, presenting you with a definition and some evidence around why it matters. I'm also going to share with you some tips for practice so that we can maximize the potential for many women to have a normal birth experience. Here's a photograph of me just to introduce myself, to show you that I've been a midwife for 40 years. I started to train to be a midwife in the 1970s. I'm a mother of 4 children. And I spend my time now running an organisation which is a learning platform for midwives and maternity workers. I deliver presentations all around the world. So the middle photograph you can see is me with Professor Sue Down, sharing a workshop in Australia on the importance of kindness and compassion and respect. I also write articles and I contribute to book chapters and I write my own books too. So let's look at what normal birth is. Here's one definition taken from Manna, which is really explaining what physiological childbirth is. There are many terms used for normal birth, but for this presentation, this is what I'm going to use. And this is a definition that I feel aligns with my philosophy. So what this definition tells us is that this normal birth should include biological and physiological conditions that promote effective labour, that it results in a vaginal birth of the infant and placenta, that it results in a physiological blood loss, that it optimises newborn transition through skin-to-skin contact and keeping mother and baby together, and it supports the early initiation of breastfeeding. But things can disrupt normal childbirth. So induction of labour, for example, an unsupportive environment where there's bright lights, cold rooms, lack of privacy, lack of supportive companions, time constraints, either those introduced by the policies of the institution or by staffing, nutritional deprivation, so not allowing food and drink during labour, pain relief, some of the pain relief methods such as epidural and heavy opioids, episiotomy, instrumental birth, including cesarean section, immediate cord clamping, separation of mother and infant, and really any situation where the mother feels threatened or unsupported. First of all, it matters that we monitor how babies are born. So we monitor the way that the baby is born from the mother, so that we can look at the short and long-term outcomes of the health of that child and of the mother. And this research study looked at 35 studies, so it synthesized other studies taken from 19 countries, and it has a moderate to high confidence level. And it said that most women want a physiological labour and birth, whilst acknowledging that it can be scary and unpredictable, and sometimes they need to go with the flow. Women also said that if intervention was needed, they needed to keep a level of control throughout the process, and that mattered to them. So this is about what women want. And in a book that I edited with Professor Sue Down, looking at a normal birth right across the world, we invited experts to contribute to the book, and Sarah Buckley and Kirsten Moberg wrote this as part of their chapter. And what they're explaining is that this is a biological complex process, and that from pregnancy right through to postpartum period, the neurohormonal system facilitates adaptive physiological processes. And really, when we look at climate change and climate control, we have to think of childbirth in the same way. We have to respect and keep these physiological processes intact in order for us to go forward with our future. This is just one piece of a plethora of evidence that looks at the short and long-term implications of the way a baby is born. And this robust study that was carried out in 2018 concluded that children born by spontaneous vaginal birth had fewer short and longer term health problems compared with those born after birth interventions. And this wasn't just cesarean section or instrumental birth, it was also antibiotics during labour. So these are the things that we have to be really thinking about all the time: induction of labour, drugs during labour, and the way the baby's born. These are all interventions that actually potentially can impact on the short and long-term health outcomes of that baby. So this is in addition to the mother. And as midwives, for midwives in the room or student midwives, remember that promoting normal birth and supporting the processes are part of our scope of practice, as outlined in the ICM standards. And again, you know, this is what we do, this is our job. So it's always worth keeping that in mind. The Lancet Midwifery series that explored and defined what midwifery is clearly states that the core characteristics of midwifery include optimizing normal biological, physiological, social and cultural processes of reproduction and early life. So again, it's there as a firm evidence base. So let's look at what's going on around the world. First of all, I'd like to just state that although cesarean section is just the tip of the iceberg, it's really one that's worth mentioning, because as cesarean section rates rise around the world, we have to pay attention to the implications of that. Dr. Neil Shah is an esteemed obstetrician from America, and he clearly states that when cesarean section is carried out, there's a severe risk of hemorrhage, bad infections like sepsis, organ injury, and it's around three times higher with cesarean section compared to not having C-section. But the real harm from these operations actually comes later, which is part of what makes it so insidious. Now, we all know that cesarean section is life-changing, is life-saving. My children, some of my daughters have had cesarean section births and they needed them. The person in the photograph is a friend of mine. Absolutely imperative that we have this operation. But we're very sorry to say that we're doing it too often in many places and in many countries, which I'm going to come on to. This gives you an idea. It's only a snapshot, not every country is included, but just look at the difference between the cesarean section rates in Israel and those in Turkey. Why is there such a huge difference? When you look at the data around this, there isn't any difference between the genetics, between the cesarean section rate is right across the board. So even, you know, sometimes we hear some statement that says, oh yeah, but women are now, they're less healthy. We've got more assisted conceptions. Women are older when they're having children, but actually the cesarean section rate is going up in low risk women too. And there shouldn't be these disparities. This is all in relation to practice and what is happening to pregnant women when they come to have their babies. So the Organisation for Economic Cooperation and Development, who produced those statistics, said while cesarean section is required, which is just what I've just said, and beneficial, it continues to result in increased maternal mortality and maternal and infant morbidity, increased complications for subsequent deliveries, and financial costs, raising questions about the appropriateness of some cesarean deliveries that not be medically required. So let's just look at now at the Lancet Maternal Health Series, which in 2016, Miller clearly said that in some countries there's too much intervention and in others there's too little. So women are dying from both causes and there's harm being caused because there's too little or too late. In some countries, such as India, that disparity happens both ends of the spectrum. So in some parts of India, there isn't enough resource for cesarean section, and in other parts of the country, there's too many being performed. And we have to try to bring this together and to stop the dichotomy here. So you can see from this graph, just a snapshot again, looking at which countries have overuse, and they're in the dark red, and underuse is the burgundy. So, and you can see the percentages right across the board, and this is from the World Health Organization. So, you know, we have these huge inequalities that are causing harm. In America, this is one country where there's too much too soon in most of this country. And again, Neil Shah has been very clear about what's happening in the USA. So it matters because women in the USA are 50% more likely to die in childbirth than their own mothers. And I've got American families, so it means a lot to me and obviously to the mothers that are having babies. And here you can see that the top line here, the pink line, is the US, and other countries such as Western Europe, Ireland, Italy, and Spain, the UK, and Germany, and Norway, the cesarean section rates are going down or they're static. So this is unacceptable. And it's even more unacceptable because when you look at the death rate in that country, it kind of, you know, it doesn't, it's obviously not showing that by doing more cesarean sections, we're keeping mothers safe, because quite the opposite. And what Neil Shah also highlighted was that it depends on which hospital, and this is in America, of course, whether you're likely to have a cesarean section or not. From one American hospital to the next, the cesarean rates vary from 7 to 70%. So what's the percentage in your hospital, and how does it compare to others in Saudi Arabia? Really worth looking and thinking about. We also know that around 30% of women find their aspect of their birth traumatic. And this is an old reference taken from Jenny Gamble in 2002. So we know that actually this is increasing year on year. This seems to be one of the clearest pieces of research that was done around birth trauma, so I still use it. But you know, this shouldn't be happening. Women shouldn't feel traumatized at this special moment of their life. That has huge consequences, not just for their mental health, but for the mental health of their baby and their family. The FIGO, the Organization for Obstetricians, the Global Obstetrician Organization, says that cesarean section rate has to be stopped. This is actually from their paper, and that's quite a clear instruction. And what the World Health Organization says, that the cesarean section rates of more than 10 to 15% are unlikely to improve maternal and perinatal outcomes, so more likely to cause harm than good. So why do midwives matter? Given that this is a midwifery presentation, it's really important that we look at why midwives matter within this context. First of all, I'd just like to highlight the fact that midwives save lives, and the evidence is very, very clear that we can save 80%, we can improve 80% of maternal and child deaths by increasing the midwifery presence in countries. Midwives that are regulated, midwives that are that are trained appropriately to ICM standards and that are supported in their practice. But also they matter within the evidence because actually in the United States, for example, which I've just been talking about, access to midwifery care correlates with improved outcomes, increased breastfeeding, reduced interventions, lower neonatal death, and increased vaginal delivery and VBAC. So direct access to midwifery, that's what it brings. And taken from Europe, you know, there's lower medical intervention rates when low-risk women access midwifery-led settings. So keeping low-risk women with midwives really does make a difference to that intervention rate. Continuity of midwifery carer, women are less likely to have epidurals, less likely to have episiotomy, preterm birth, baby loss, more likely to have spontaneous vaginal birth. And relationship, you know, this really matters, less likely to have episiotomy, less likely to have a baby born before 24 weeks. So, you know, relationships matter completely. So what can you do in your practice to support normal birth? First of all, go back to basics, really revisit what you learned during your training, or even if you didn't learn all about the physiology of labour and birth, then the complexities of the hormonal processes, then go right back. And a great website is Dr. Sarah Buckley's. She's a GP in Australia, and she's got a platform there where you can access absolutely amazing information that goes into great detail of why it's important to understand the physiology and what you can do to maximize physiological environments for women. This is one of the things we can do, is turn off the lights. So have some lighting. These aren't real candles, they're battery operated, and, you know, excellent for keeping the mood right, because we know that darkness supports the physiological process. So here we have a high-risk obstetric unit where midwives have put small lights in that twinkle, and they call it twinkling the rooms. So you can see that they've darkened the rooms. Even in a high-risk setting, you can do these things. Putting notices on the door to ask people to be quiet, not to enter unless it's absolutely necessary, and to knock, of course, before you go in. Continuous support during labour with birth partners, doulas and midwives encourages shorter labours, supports vaginal birth and women's satisfaction with their care. Again, taken from our book, Squaring the Circle. We also have to make sure that midwives and birth workers are absolutely supported within their practice so that they can give friendly support in labour. So smiling with your eyes, even when you've got a mask on, a woman can see whether you're smiling or not. So that your body language, the way you approach her, your eyes really make a difference, because it reduces sympathetic activity and increases parasympathetic activity for the labouring woman and triggers the hormonal and neurohormonal conditions that enable an efficient and safe labour and birth. And organisations have to foster a culture of compassion and positivity. For example, by valuing staff. So if organisations are being supportive to midwives and maternity workers, then the midwives are more likely to support, and then that helps maximises potential for normal birth. So it's all a big circle. We also have to create a space for mothers and babies that are having a cesarean section, so that physiological processes are optimized again. So this is look at this beautiful space where the father and the mother are together welcoming that baby that's in skin to skin contact. There's been optimal cord clamping and early breastfeeding, and there's love there, there's oxytocin flowing. So even the women that can't be supported to have a normal birth, even, whatever birth they have. This should be how the birth is finalized so that the family can begin their journey together. Obviously, if there's problems during the birth and the mother and baby need extra support, then this can't happen, but it can happen soon after. So as soon as the mother and baby are well enough to be together, these things should be initiated to optimize that process. So the human rights agenda within our book, again, clearly outlines that maternity care should be rights-based and evidence-based, and I've just presented you with the evidence. It should be respectful of a woman's right to dignity, autonomy, privacy and equality, individualised to each woman and baby and not delivered like a conveyor belt. To fully respect a woman's right to choose a right care provider and for her and her baby. And it should be aimed at the realisation of the highest attainable standard for health for women and babies. So that's, human rights in care. The World Health Organization are very clear that a woman's positive experience is absolutely crucial, and that includes respect and dignity, companion of choice, clear communication by maternity staff, pain relief strategies, mobility in labour and birth position of choice. We should keep those we serve at the centre of all our actions and speak up for the rights to have enough time and resources to provide the care we're qualified to give, always. Thank you so much for listening to me today. Thank you for your time, and I'm here if you want to ask any questions either now or online later. You can find me on social media via Twitter and Instagram, and these are my Twitter handles. Thank you.
Thank you, Dr. Sheena, for this amazing lecture. It's really empowering midwifery. I like most the lighting, the obstetric unit with the twinkle twinkle thingy. It's very nice, and the heart notification for knocking door. It's always better and good if you have a love touch or a special touch for the delivery, because each delivery, it's really special. So thank you for sharing all this information, and we will go for the question. We have a question: how can we maintain normal childbirth during a pandemic while we heard about raised cesarean in some countries?
Well, thank you very much. Thank you for sharing some questions with me. I found it a bit strange watching myself just now. I've never done that before, and I looked so nervous. So it's great to be able to talk to you live, because I just feel like it makes a difference. Well, I think we're seeing all around that the intervention rates are rising during COVID, and there's no reason for that. There shouldn't be issue at all. It should be that it stays the same. In fact, in some parts of the world, home birth is being encouraged. So, women are not wanting to go into hospital because it's where sick people are. So that's kind of, that's what's happening in some areas. But certainly we just have to keep remembering that actually there shouldn't be any restrictions. We should be supporting women to, in the ways that I've mentioned, in relation to the environment, in relation to the people who are supporting them. I know that there's been some restrictions on birthing partners in most countries. I would say there's been restrictions in some areas. Birthing partners are not allowed at all, and then in others it's just been one. But that has to be. We have to ask ourselves why. Why is there so many restrictions on women, and why is the cesarean section rate rising? Because it shouldn't be the case at all. So we have to keep revisiting the evidence, looking at physiology, and looking at ways that we can optimize that birthing process.
Yeah, thank you very much, Dr. Sheena. I think this is the most important, that we need to be revising the evidence-based practice, the researches, that it's really benefit. And thank you for this great lecture.
Just to add to that, can I just add to that, Howder, that when the pandemic first hit us in March, we can understand the fear. Do you know, there was a lot of fear, and everyone was worried about bringing, so in hospital birth, for example, bringing people in, birth partners in. So because of obviously the public, you know, having more contact with the public. But I think what we've got to do all the time is review the situation. I think there has to be this constant review. So say, for example, if water birth's been restricted, why is that happening? You know, we need to keep reviewing it and going, like we said, going back to the evidence to check.
So, okay, we have another comment just coming. My sister is about to deliver. Doctors say that if her baby will raise, she will be for cesarean. How can she manage everything to control her baby earlier in her pregnancy? She had higher baby, but thank God it was managed. Thank you in advance, Mom.
Okay, so that's
What about blood pressure?
yeah, I can't really give any advice on that. That's asking for sort of medical support. But I think that what she needs to do is stay close to her medical practitioners, her obstetrician and midwives, and get checked. I mean, it's important if her blood pressure's up that she's carefully monitored. And without any other information, and really I'm not here to kind of give that advice, but she does need to take care if her blood pressure is raising.
Okay, a third question. Thank you, Sheena, for the wonderful presentation. What have you taken from developing countries back to UK that has worked well? Was there anything from the UK that you have shared in developing countries for their benefit?
Into developing countries, did she say? Did she ask developing countries?
Yeah.
So the thing that I suppose for me is the most important aspect to share with other countries, whatever the country is, whichever country it is the importance of compassion and respect. I think that so humanizing childbirth for me is the most important thing that we can do. And when we look at the humanization of birth, yesterday Lucia Rocca was talking about the biomedical biomedicine and the social aspect of childbirth, and comparing the two. And it's very similar. If we work towards the humanization of birth, that is where the mother and baby are kept together, the mother's rights are respected, she's treated by compassionate birth workers who are also looked after within their environment, and there's not unnecessary intervention imposed upon her, and her view is very, you know, her opinions and her choices are the most important thing. So she's a person in her own right and not merely a vessel for carrying the baby. And when these things are upheld within any country, then women are more likely to have a positive birth experience, and the health of the mother and baby is optimized. So I think for me, that would be the thing that I would share most with any country, is the rights of the woman, the human rights, and that she needs that dignity and respect and care and compassion that will help her to have the best birth possible.
Thank you, Sheena, for the answering. For the last question, how will you encourage skin-to-skin touch in hospital where father or the husband is not allowed in the operating theatre to improve nursing care?
Okay, that's a really good question, and I wish my friend was here, Jenny, whose big passion is skin-to-skin in theatre. There's been a lot of advances in the United Kingdom with skin-to-skin in the operating theatre. And it's really important that we work with the practitioners, with the theatre attendants, with the anaesthetist, with the nurses in theatre and the obstetricians to enable this to happen, because it's so important that mothers and babies that are well at the moment of birth can be together and not separated. There should be a zero separation of the two, unless the mother wants that or unless the baby is ill. And so we have to look at ways. So that the things that they've done in the United Kingdom is by making the drapes, make so that the drapes that are up, you know, sort of having the woman accessible, making sure that she doesn't have a gown on that's covering the front, that she wears it the other way around, putting the electrodes that are usually on her chest on her back. So there's lots of ways that you can do that. But the first thing so those are practical tips to actually making it happen. But first of all, you need to meet with the theatre practitioners and collaborate with them and give them the evidence why it's important for mothers and babies to be together in that moment, because what it does is it gives the mother and baby and the partner, if there is one, that best possible chance for a good family life, for a really good start. And that's what we should all be doing. We should all be looking for that positive start in life, because it makes a massive difference for families going forward. And if it can't happen at that moment, what we've always got to remember is that if it doesn't happen at that very moment, we can actually do skin to skin later. So nothing's lost, you know, we can still do it, and making sure that it, you know, we remember that brings benefits too.
Okay, thank you very much, Dr. Sheena. I think there is problem in the host, or they close already our first session because we are more maybe of the time, because they told us it's gone.
Oh,
no, it's
okay.
No, it's okay. The host, he replied, he said no, it's going on.
Oh,
so
okay.
It's fine. Thank you for answering many questions, but actually we have more few, if you don't mind. There is another question. I'm happy you made the mention of organizational support, but there is some place facing racism. How can we eradicate this?
Facing racism, okay, yeah, this is a massive issue in the United Kingdom as well, and in many other parts of the world.
I see like Black Lives Matters hashtag and everywhere nowadays.
Yes, absolutely. And I think it has to be, we have to continue delivering these messages of that Black Lives Matter, and show people the evidence, because actually women are dying. So women and babies are dying because of racism, and it's unacceptable. We have the statistics, for example, in the United Kingdom, that this is the case, and in America. So my advice would be to keep educating and to keep you know, sort of speaking out about it, speaking up, speaking out, and checking when you hear racism, not kind of being implicit in it, not sort of ignoring it, but calling it out if you hear it, and helping others to understand the importance of and the unacceptability of racism in any context, whether it's institutional or whether it's personal. So that is unacceptable.
Yeah, thank you very much, Dr. Sheena, for this great answers and great lecture. And we are really honored to be you with us today. Thank you. And
well, can I just say one thing before I leave? It's my honor to be with you.
yeah,
And yeah, it's difficult doing a recording because I wasn't really looking at anyone. So I hope that didn't detract from the fact that it should be a personal thing. And just to say thank you again to Dr. Roa and to all of you, because what you're doing is totally inspirational. And it's people like you that make me feel really sort of that I'm so happy to be a midwife. So well done for everything that you're doing.
Thank you. Also, same feeling that you let us feel it, that we are really, I feel proud that I'm a midwife, because I see like you as a model for our future, and it's very nice to empowering midwifery. So thank you very much.
Thank you,
And
Heather. Thank you so much.
To meet you today.
Okay, thank you so much. Have a great day.
Thank you.
Bye. Bye.
So thank you to attend our first session today. Don't forget to please visit and check our posters and leave us, please, the comments on the posters. And now we will go for a break for 45 minutes, and we will come back for the second session. So please to continue this lovely lectures. CME hours, it will be accredited because I think this is the most frequent question we can face, and it will be available in 14 days. So please fill out the evaluation form that we will be sent to your registered email ID to obtain the CPD credit hours. And thank you, and see you soon. Please, please, please double check the posters. Thank you very much for attending today, and see you soon after a while to start the second session. Thank you, everyone.